Hello Copperheads, my name is Kupri and my first 6 videos have all been about preparing you for this moment. Today and in the next few weeks we're gonna be learning about how to diagnose Wilson's disease. If you or someone you love is currently in the process of confirming or excluding a Wilson's disease diagnosis, it's extremely important that you become familiar with this process. Not just because it's good to know what to expect, but also because unfortunately many doctors don't know all that much about Wilson's disease and will often make mistakes. So I want you to be informed and empowered to advocate for yourself if you need to. The most important thing you need to know is that there isn't one test that can diagnose Wilson's disease. The process involves, at the very least, several blood and urine tests and can also include even more blood and urine tests, an abdominal ultrasound, a liver biopsy, a brain MRI, and a genetic test. The particular combination of tests is gonna depend on each case, but there are 4 crucial values that always need to be measured when assessing the possibility of a Wilson's disease diagnosis. These crucial values are serum ceruloplasmin, total serum copper, free serum copper, and 24-hour urine copper. Today we're only gonna cover the first one, serum ceruloplasmin. The serum is the portion of your blood that is neither blood cells nor clotting factors, so it includes all the proteins that are not involved in blood coagulation, as well as hormones, antigens, antibodies, ions, etc. We measure the concentration of ceruloplasmin in your serum because this value is decreased in people with Wilson's disease. The CP gene makes ceruloplasmin. Ceruloplasmin is a protein, specifically a peroxidase enzyme. That means it's involved in iron metabolism. You might be wondering, if it's involved in iron metabolism, then why do we look at it when diagnosing Wilson's disease, which is a condition of copper metabolism? Well, let's make this explanation fun by playing with some Legos. So, the CP gene tells me how to put these white and yellow Lego pieces together to make apoceruloplasmin. Apo comes from Greek, and it means away from or detached. Apoceruloplasmin is ceruloplasmin that is not bound to any copper ions, which are these loose red Lego pieces. And this is where protein ATP7B comes in. Protein ATP7B attaches 6 copper atoms to apoceruloplasmin, and by doing this transforms it into holoceruloplasmin. Holo also comes from Greek, and it means whole or complete. There are 2 important differences between apo and holoceruloplasmin. The first difference is about activity. Apoceruloplasmin on the left is missing those 6 copper atoms, and it doesn't have the right shape to interact with this black and blue Lego molecule I have over here. The shape is not right, so it's not able to do its job as part of iron metabolism, so we say it's biologically inactive. Holoceruloplasmin on the right does have the 6 copper atoms, and it does have the right shape to interact with my black and blue molecule. So it is able to do its job as a peroxidase enzyme, and we say it's biologically active. The second difference between apo and holoceruloplasmin is about stability. My Lego pieces on this apoceruloplasmin molecule on the left don't have many attachment points, so if I play with it a little bit, the pieces quickly fall apart. But my holoceruloplasmin molecule on the right is more stable thanks to these copper atoms, so it takes a lot more effort to take it apart. We saw in the Copperheads 4 video that if you have Wilson's disease, your protein ATP7B is not able to load copper ions onto ceruloplasmin very well. This means that if you have Wilson's disease, you end up having a higher proportion of the less stable apoceruloplasmin and a lower proportion of the more stable holoceruloplasmin. So even though Wilson's disease doesn't cause you to make less ceruloplasmin, it does cause it to break down faster. So overall, you end up having a lower concentration of ceruloplasmin in your blood serum. But how low? Well, most labs consider that the normal range for adults is 200 to 500 milligrams of ceruloplasmin per liter of blood serum. And both the European and the American Wilson's disease guidelines agree that values below 200 milligrams per liter strongly indicate Wilson's disease. And I'm saying strongly indicate because the concentration of serum ceruloplasmin alone is not enough to confirm or exclude a Wilson's disease diagnosis. If your doctor tells you that you don't have Wilson's disease just because your serum ceruloplasmin is within the normal range, you need to know that it's perfectly possible to have normal ceruloplasmin levels and still have Wilson's disease, because every particular body and situation is unique. Yes, Wilson's disease lowers your ceruloplasmin concentration, but there are other factors that can raise it. So your result can end up being within the normal range, and doctors can end up concluding that you don't have Wilson's disease even if you actually do. The three big factors that raise serum ceruloplasmin are: number one, age. Before 6 months of age, ceruloplasmin is very low. Then it peaks, and after 1 year of age, it drops again. After that, it slowly rises as we age. Number two, estrogen. More estrogen, more ceruloplasmin. And this is a very important topic that will get its own video in the near future. And number three, inflammation. If you have inflammation in your body, for example, due to liver failure, arthritis, or whatever, your ceruloplasmin levels are also increased. Additionally, here's the thing: there are two ways to measure serum ceruloplasmin in the lab. Method number one is immunological and uses an antibody that reacts specifically to human ceruloplasmin, but does not distinguish between biologically inactive apoceruloplasmin and biologically active holoceruloplasmin. Method number two is enzymatic, and it measures only holoceruloplasmin because it's biologically active. In people without Wilson's disease, these two methods give almost the same result, because these people have very tiny amounts of apoceruloplasmin, the biologically inactive form. But people with Wilson's disease have a lot more apoceruloplasmin, so if they get tested using an immunological method, they can get a result within the normal range, when in fact the biologically active and biologically relevant holoceruloplasmin form is quite low. So now that we have covered why a person might have normal ceruloplasmin even though they have Wilson's disease, let's talk about what might cause a person to have low ceruloplasmin even though they do not have Wilson's disease. Number one, we have severe copper deficiency. Number two, we have severe liver damage for any underlying reason. Number three, we have other conditions such as Menkes disease and aceruloplasminia. And four, we have been a carrier but not a patient of Wilson's disease. As we covered in Copperheads 2 and Copperheads 3, carriers can have somewhat abnormal copper metabolism, but it's not bad enough for them to actually develop the disease. So the main conclusion of this video is: serum ceruloplasmin can give us useful and crucial information, but at the same time we have to be very careful when interpreting this value. We have to look at it in the context of the particular patient, and we always have to consider the bigger picture of all the other test results that we will continue to cover in the next few weeks. I just want to tell you one more thing before we go. Last week I went on and on and on about the importance of always saying the units. This is because different labs are going to use different units to measure serum ceruloplasmin or any other value. The normal serum ceruloplasmin range for adults is typically 200 to 500 milligrams of ceruloplasmin per liter of human blood serum, but some labs might express the same values using other units, for example, milligrams per deciliter or grams per liter. Let's take, for example, 350 milligrams per liter, which is right in the middle of the normal range, and convert it to milligrams per deciliter using the math skills we developed last week. First fraction, which is 350 milligrams per 1 liter, multiplied by a second fraction, which is 1 liter per 10 deciliters. Liters cancel each other out, so this equals 350 milligrams per 10 deciliters, which equals 35 milligrams per deciliter. Now let's take 350 milligrams per liter and convert it to grams per liter. First fraction, which is 350 milligrams per 1 liter, multiplied by a second fraction, which is 1 gram per 1000 milligrams. Milligrams cancel each other out, so this equals 350 grams per 1000 liters, which equals 0.35 grams per liter. So you see, 350, 35, and 0.35 look like very different numbers, but when we attach the correct units to each of them, we can see that they all mean the same. When discussing your test results with other people, you always need to say the units. I see communication problems because of this all the time in online patient communities. Person A comes and says that their serum ceruloplasmin is 35. So person B assumes the units are milligrams per deciliter and says, oh, that's normal, don't worry about it. But person C assumes the units are milligrams per liter, so they say, what are you talking about? That's really low. And then an argument ensues because people are not realizing that the lack of units is causing all this confusion. Alright, Copperheads, that's all for today. Come back next week to learn about the very important blood and urine copper tests. Until then, you can find me on YouTube, Instagram, Facebook, or by email. My name is Cupri. See you there, Copperheads!